Please note, the opinions expressed in this podcast are those of the individual speakers and do not necessarily reflect the views of Tri-County Orthopedics. Any medical advice or treatment recommendations discussed should always be reviewed with your own healthcare provider. This podcast is not a substitute for professional medical advice, diagnosis, or treatment.
All right, welcome back to the OrthoZone. We are here with Dr. Shearin. He's back again. If you haven't already listened, go listen to his first episode, which is all about carpal tunnel. Dr. Shearin is one of our hand and upper extremity specialists here at Tri-County Orthopedics, and he's here again today to talk about lateral epicondylitis, otherwise known as tennis elbow. So welcome back, Dr. Shearin.
Thanks for having me, Olivia. Happy to be here.
All right, so I thought for this episode, we would just start with what is lateral epicondylitis for those who don't know.
So lateral epicondylitis is also known as tennis elbow, and it is the most common cause of lateral elbow pain that presents to our office. And essentially what it is, it's a very painful and limiting entity of the upper extremity that patients experience on a day-to-day basis. And it is so common that I see it regularly in the office from a hand and upper extremity standpoint, and also a lot of non-surgical orthopedic doctors and physiatrists and primary care physicians also see this common condition called lateral epicondylitis in the office. And essentially what it is, it's a tendinosis of one of the extensor tendons on the outside of the elbow. It can be confused or mistaken for a tendinitis or an inflammation, but it's more of a tendinosis or a degeneration of one of the tendons on the outside of the elbow. Now, the outside of the elbow has several tendons that contribute to extending your wrist, extending your digits, and also extending your elbow. The tendon that's problematic in this condition is the ECRB tendon, which is the extensor carpi radialis brevis tendon.
So how did lateral epicondylitis become commonly known as tennis elbow?
So that's a great question. So this was described by Morris back in 1882 as lawn tennis elbow. And the reason for that is because it was originally described and seen more commonly in patients who play tennis. The reason for that is because as tennis players utilize their backhand and are extending their elbow, extending their wrist, a lot of forces are placed on the outside of the elbow. Therefore, patients playing tennis more commonly suffered this condition of lateral epicondylitis. Therefore, it was entitled or named tennis elbow.
So what causes lateral epicondylitis on a physiological level?
That's a really good question. So as we talked about earlier briefly, it's not really an inflammation of the tendon. We can think of it like that, but it truly is a tendinosis. So when you look at the tendon under a microscope, what you see is not an inflammation. You don't see inflammatory cells, but you see granulation tissue. You see degeneration of the tendon. And what you see are these little vascular buds or vascular channels, granulation tissue, and more of a degeneration of the tendon. That's what you see on the microscopic level. And what can happen is these changes lead to small microscopic tears within the tendon. As those microscopic tears get bigger and get more significant, it can sometimes lead to larger tears on the outside of the elbow.
And so what are some early signs and symptoms that people should look out for, or how are your patients presenting in the office?
So most commonly, when patients come in, they're complaining of pain on the outside of the elbow. Lateral epicondylitis or tennis elbow is the most common thing that I see in the office as it regards to elbow pain. Most patients are complaining of pain on the outside of the elbow with any type of gripping activities. When they grip their coffee cup, when they grip their glass of water, they have pain that radiates from the elbow down the arm. Anytime they're lifting their bag or a book or a magazine, they're reporting pain on the outside of the elbow. So what they describe is not just pain with exercise or pain with athletics. They describe daily functional pain with activities of daily living, mainly centered to the outside of the elbow. Now, because the one tendon that's affected is the extensor carpi radialis brevis tendon, there are other tendons, however, around this same area on the outside of the elbow that can become inflamed. And what we can see is the pain not just on the outside of the elbow, but it can radiate down the forearm. So at times patients have forearm pain that can radiate from the elbow down the arm.
And what does a typical diagnosis process look like in the office? Are you doing imaging, like MRI, X-ray, anything like that?
Good question. So I think the most important thing when I evaluate a patient with possible lateral epicondylitis is their history and their physical exam. So the story they tell me, and when I examine them, I can glean everything I need in order to make an accurate diagnosis of lateral epicondylitis. Now, additional factors that can help would be things such as X-ray, ultrasound, and MRI. The idea with an X-ray, what I'm looking for in an X-ray, is there any previous injury to the elbow? Has the patient had any other surgery in the elbow? Are there any calcifications on the outside of the elbow adjacent to the lateral epicondyle? At times, calcifications can represent trauma or injury or tendinosis on the outside of the elbow, which is why I look for calcifications. Further imaging are things such as ultrasound and things such as MRI, which are part of the process.
Are there any common conditions that are misdiagnosed as tennis elbow?
Yes, so we have to rule out other conditions such as arthritis of the elbow. So when someone comes in with lateral elbow pain, what's on my radar is a somewhat short list of differential diagnoses. These are things that the patient may have that appear similar to lateral epicondylitis, yet the treatment would be very different. This is arthritis of the elbow, number one. Number two would be tendinosis or tendinitis of the triceps tendon, which is on the back of the elbow. Another possibility would be lateral ulnar collateral ligament insufficiency or lateral ulnar collateral ligament tear, which is injury to the ligament on the outside of the elbow. The other possibility would be posterior interosseous nerve compression syndrome, which is compression of the nerve adjacent to the elbow. I think the arthritis, the nerve compression, the ligament insufficiency, and the triceps tendinitis are the main things that are on my radar when I'm thinking about a patient coming in with lateral elbow pain. So we have to make sure we rule out those prior to proceeding down our non-surgical treatment for tennis elbow.
So we've gone over symptoms and diagnosis. So in terms of treatment, what is the most effective conservative treatment options for patients?
I think we have to start with stopping or modifying any activity that causes pain. So if the patient is avid in tennis or squash or lifting weights or other racket sports, if those activities are causing pain, discomfort in the outside of the elbow consistent with lateral epicondylitis, we do have to stop that activity. If we don't stop that activity, the elbow is going to continue to have pain and discomfort. So number one, we have to modify or stop any provoking activities that have caused the lateral epicondylitis. So number one, we have to stop the activities that are causing the symptoms. Other conservative treatment options, I do like to start with a short course of an anti-inflammatory medication if the patient can take that. And that's something that involves over-the-counter anti-inflammatories like Advil or Tylenol, or at times we can do a prescription anti-inflammatory, which we could talk about in the office, for a short period of about 10 to 14 days. And that's if the patient can take that given their medical history. Other conservative treatment options we think about are splints. So splinting for the wrist or braces for the elbow. The splinting for the wrist, what that does is that prevents wrist extension, and by extending your wrist, that can actually fire or load your elbow. So by preventing the wrist extension, you can decrease the forces that are going through the elbow, thereby improving pain. Other things we think about are braces, such as counterforces braces that go on the outside of the elbow. Now what these are basically pads that provide a compressive force on the muscle bellies of the extensor muscles. And what this pad does is it limits the excursion of the muscle, therefore decreasing the force on the origin of the muscle. The other mainstay, in my opinion, is physical therapy. I think therapy is something that is invaluable in the non-surgical management of lateral epicondylitis. It's widely recommended. Many studies have shown positive benefits of physical therapy, and this can include a variety of things. This can include heat, it can include ice, it can include manipulation of the elbow, it can include massage, stretching protocols, and strength strengthening protocols. It's very important before the patient even engages in therapy that they're working on a stretching regimen at home. And this stretching regimen is keeping the elbow extended and bringing your wrist down into flexion, which produces a stretch on the outside of the elbow where those tendons are aggravated. So this is elbow extension and wrist flexion, and you push down gently on your wrist to stretch out the outside of the elbow. So the therapist and myself in the office will be able to teach you these exercises in order to improve your pain.
And then where do things like cortisone injections fit into the treatment plan?
So when therapy has failed, we start talking about other options. Another important aspect of therapy is a concept called iontophoresis and phonophoresis. These are treatment modalities in which low velocity electrical current for the iontophoresis and phonophoresis, which is low velocity ultrasound, what they do is they drive these topical medications, either cortisone or non-steroidal anti-inflammatories, into the deeper soft tissues. And your therapist will be able to perform these most of the time, iontophoresis and phonophoresis. Now, when all of this has failed, when we think about the patients come to me the first time, we've diagnosed them with lateral epicondylitis, we try the splint, we try the elbow pad, we start our anti-inflammatories, we modify our activities, we've done our therapy. 8 weeks later, they come back to see me and they say, "Doc, I'm still having trouble. What's next?" At this point, if the patient is truly suffering, which they are because they're back in my office, we start thinking about other interventions. Other interventions involve things such as cortisone injections and even things such as PRP, which is platelet-rich plasma injections. Now, there's a lot of mixed data, good and bad, looking at cortisone injections and PRP. Some studies say that they work, other studies say that they don't work. My goal is when the patient is in my office having a difficult time with their elbow, I want to do anything that I can to make them better and improve their pain. This is when we start talking about other options like cortisone or PRP.
So for all of these conservative treatment methods that we've talked about today, how successful are they, or are you usually ending up recommending surgery?
That's a good question. When I think about this condition, Olivia, this is something that oftentimes will get better, meaning rarely does someone need to go to surgery. Most of the time, literature and data says that this can be 12 months to 24 months before a patient will get better. That's a challenging, extended amount of time that a patient has to suffer and bear with this ailment and bear with this pain. But I would say on the most part, over 95% of patients will get better without any surgical intervention. Prior to considering that, PRP and cortisone injections can be used. However, the data to support those are mixed. Some data says that there's no difference between a cortisone injection, a PRP injection, and just injecting saline into the outside of the elbow. Some data says that the first 4 weeks with a cortisone injection, patients feel fantastic. However, there's no difference, or sometimes they feel worse at 6 months or later. So I try to caution my patients regarding all these possibilities. And it goes back to the concept that lateral epicondylitis, while the most common cause of elbow pain, there's still a lot that we don't know. We understand the pathology. We understand it's a tendinosis or a degeneration of the tendon. We understand that there's granulation tissue, that there's a lack of inflammation. We understand that these can progress to larger tears and cause disabling and functionally limiting pain. I try to tell my patients that despite all these, despite how limiting this can be, and I know because I've had it myself, oftentimes it will get better, but it can take up to 18 months to 24 months to get better.
So if someone does need surgery for tennis elbow, what does that involve?
So as we mentioned earlier, I will get an x-ray in the office to assess for calcifications or any type of bony abnormality. If we have attempted non-surgical management and exhausted non-surgical management, and it's been at least 12 to 18 months, we will consider a surgical procedure. I always will obtain an MRI prior to surgery for 2 reasons. Number 1, I want to know if this microscopic tearing or this microscopic degeneration has led to a partial tear or a complete tear of the extensor carpi radialis brevis tendon or the extensor wad muscle. Thereby, I can be appropriately prepared and plan accordingly for the surgical procedure. That's the goal of the MRI, number one. Number two, the MRI tells me if there's other pathology that could be mimicking lateral epicondylitis, such as posterior interosseous nerve compression syndrome, where you can at times see a cyst or a mass adjacent to the posterior interosseous nerve, or the MRI will show if there's any lateral ulnar collateral ligament insufficiency or tearing, which could explain patient's lateral elbow pain. This is another reason I get the MRI prior to surgical intervention. If we do proceed with surgery, this is a surgery that's done as an outpatient procedure. It's an in and out where you come in the morning, you go home the same day. The patient gets twilight anesthesia or sedation. A small incision is made on the outside of the elbow, and I remove or excise the degenerated tissue, repairing the healthy tissue back down to the bone. Oftentimes, you can see the degeneration in the extensor wad tissue. So the poor degenerated tissue is excised, and then the healthy tissue is repaired back to the bone. The patient is then placed in a splint and goes home the same day. This is a very low-risk procedure, and I generally state the success is about 80 to 85% success. We see the patient in the office in about 10 days, and we get the stitches out, and then we start therapy. On average, the recovery is about 8 weeks to 16 weeks. Patients are doing therapy during that time, but full recovery, getting back to tennis, racket sports, exercise, squash, is between 12 and 16 weeks on average. With the procedure, patients generally have light sedation or twilight anesthesia, in which the outside of the elbow is numbed with a local anesthetic. Another thought in regards to the surgery is that there are two different ways to do the procedure. Procedure can be done arthroscopically, or the procedure can be done in a mini open fashion. I believe the success is comparable and the outcomes are comparable in my opinion.
Has your approach to treating tennis elbow changed over the years with new research or technology?
That's a good question. I think the exciting aspect of orthopedics is that there's always innovation, there's always progress, and we're always trying to do things better to help our patients better. And that's one thing that we pride ourselves in here at Tri-County, always looking at the research, looking at the data. How can we make our patients better more effectively? One aspect of tennis elbow that I've learned and gained more insight on in the last 5 years in my practice is that this can take time. We have to be patient with our patients and counsel them that this can take 12 months to 18 months, and some data says 2 years. You can outlive this condition. As we said in the beginning, this is the most common cause of lateral elbow pain. This is a very functionally limiting condition. I've had it myself. I know, I understand. That's why I do not want my patients to suffer. So I do everything I can to make their life better, easier, more tolerable, so they can be the parent, the spouse, perform the job, the exercise that they would like to do without pain. The other challenging aspect about lateral epicondylitis is the data is mixed. There's still a lot that we don't know. Some studies support therapy, other studies don't. Some studies support an injection, others don't. So there's no true consensus. So from a provider standpoint, there's not one thing or two things that we can offer. We try to tackle this in a multifaceted approach, understanding that some of the data is mixed, but I can offer you many different things to try to help. One of the most fantastic advances, I think, over the last 10 years is PRP. What PRP is platelet-rich plasma, and that's where you spin your blood down and we get the platelet-rich cells, the pro-healing mediators, and we inject those into the lateral epicondyle or lateral elbow. Now, the effects of PRP injections are still under evaluation. And again, the data is conflicting. There's not one treatment in lateral epicondylitis per se that works 100% of the time. PRP, the data is somewhat conflicting, but studies have looked at outcomes of PRP injections. And there are studies that have shown that a single PRP injection produced greater pain relief and better performance scores than therapy alone. That's why I will offer PRP. And I have found patients come back to the office and been relieved with PRP. So I think that's something that we should consider. It's something that is an option. Again, we're trying to avoid surgery, avoid the next step, and this is one of the treatment algorithms that I utilize.
So what are the biggest mistakes people make when trying to treat tennis elbow themselves?
I think the biggest mistake, Olivia, is they take a break from that particular activity, whether or not it's golf or tennis or squash, exercise, but they don't take a long enough break. I see patients come in to my office in a lot of elbow pain and they've taken a 1 week or 2 week break. That's not enough, in my opinion, to allow this degeneration and this problem to heal on the outside of your elbow. So when I see the patient in the office, we counsel them on all options to treat their lateral epicondylitis and also the appropriate amount of time to take a break from that particular activity, which I would say would be at least 6 weeks.
And so what is one of the most common questions that you get from your patients about tennis elbow?
The most common question is, will this ever go away? Implicit in that statement is, this is a very disabling, frustrating condition, and it's the most common condition that presents to my office in regards to lateral elbow pain. So everybody wants to know, when will it go away and how to deal with it? Generally, it can take 12 months to 18 months to go away, and I have a myriad of options that can help you deal with this condition. And I've had success in the past, and I'm happy to help.
All right, so I think we covered a lot, but to end, I thought it would be interesting because this condition is called tennis elbow. Any advice for tennis players experiencing lateral epicondylitis?
Great question. While it is called tennis elbow, I will say wholeheartedly that a lot of my patients who come in do not play tennis, and that is very, very common. So for those who do play racket sports, or they play golf, or they squash, tennis, exercise, and they have lateral elbow pain consistent with lateral epicondylitis, what you can do in order to attempt to mitigate this is, prior to engaging in that sport, make sure you're stretching your elbow. Stretch it for 15 minutes, loosen it up, number one. Number two, the other thing is a heating pad. So what a heating pad does, it increases the blood flow to that area, and you can put a heating pad on in conjunction with stretching 15 minutes prior to playing. You play your sport, you're done, you again stretch your elbow. The stretch is like we discussed, elbow extended, wrist flexed, and you're pushing down on your hand to stretch out the elbow, and then you're icing your elbow. So for those athletes out there, heat and stretch before, play, and then stretch and ice after. Those are the important things.
Okay, well, I think that was a great episode, very successful, and if anyone has any questions, come see us at Tri-County Orthopedics.
I'd be happy to help. Olivia, thanks for having me. And hopefully the audience learned something about lateral epicondylitis, also known as tennis elbow.
If you enjoyed today's episode, be sure to subscribe so you never miss an update. Don't forget to share the podcast with others who might find it helpful, and follow us on Facebook and Instagram at Tri-County Orthopedics to stay connected. Thanks again for tuning in, and we'll catch you next time.